Okay, so welcome everyone to this inaugural Cerebral Palsy Education Day, where we're going to be presenting new information about early identification, surveillance and beyond in cerebral palsy. Before we get into the program, I would like to welcome Fraser Toy to open our meeting with a traditional Maori blessing, or karakia. Fraser is our local kamachu at ADHB. And over to you, Fraser.
Kia ora. No mai haere mai tātou katoa. Welcome to you all, special people with the special service that you provide. E mohina tātou ngā kaupapa katoa e timata I te tahi krakia. We all know that in tradition, these sessions always begin with a karakia. So, kia inui tātou, let us pray. Kei mua koe ia mātou e iho. Hei kai arataki, hei kai manaki ia mātou. Ko koe ana he whakakaha ia mātou kia whai krori ai koe I roto I o mātou mahi katoa. Hei mea timata, he mea mahi, hei mea whako oti I roto I a koe kia whiwhi ai mātou I ngā mea katoa e tūmana ko tēnei e mātou. Pera I te ora tonutanga. Mātou ariki a hehu kraiti. Amen. Wendo, kanui tēnā, welcome to you all again. As I said, ngā mātanga hauora. To all you special people in the special service that you provide to do with this Cerebral Palsy Education Day. Welcome to the kaupapa today. E mihi nui tēnei kia koutou katoa. Noku te honere ki te mihi ati kia koutou mai I te taha o taku tūranga hei kaumātou mo te kaunihera kaumātou o Waitemata Rāua ko Tāmaki. And it is my honor to welcome you all to this special session of yours today on behalf of the Council of Kaumātua for Waitemata District Health and Auckland District Health. Weno waiho wene krakia hei manaki hei tiaki a koutou I roti tēnei kaupapa kei mui a koutou. We'll let these prayers bless and lead you in everything that happens from here on in your webinar session today. E mohina tātou, nāku mea tu ke roti ngā krakia kia whakatūwhera hia ngā huarahi tika. In the prayers I have asked that the channels of communication be opened because it is about listening and learning and saying the right things and doing the right things as well. Nā reino hone ko te tūmana ko, kia pai te haere o tō koutou rā ākua I a tō koutou kaupapa. The hope is that everything runs smoothly for you in your session today, that you'll achieve all the things that you are hoping for, and maybe something new will come out of it. If so, then grab it and take it, and of course, use it to the services that you apply. Waiho manga krakia he manaki a koutou katoa. We'll let the prayers once again bless and guide you in everything you do today. No reira I runga te taha o mātou. I especially pay tribute to the way that we all take with us wherever we go. Our spiritual content in our culture is very important. And of course, we always pay homage to those who have departed. If you have friends, family, or somebody like that that is probably weighing you down a bit at this stage, together we will say to them, haere koutou, haere koutou, haere koutou. Moi mai koutou I roti ngari ngā ta whai o tō tātou ariki, e moi, e moi, e moi. We have just quietly said to them, just leave us for the day, but we don't forget you at all. And with that, kia koutou katoa e whakahaere na tēnei kaupapa, tēnā koutou, tēnā koutou, tēnā koutou katoa. All my blessings to you all. And thank you, and that's my lot. Kia ora.
So today we're going to be presenting on cerebral palsy in Aotearoa, New Zealand. We're presenting our capture study findings. We're also presenting the launch of this clinical network best practice recommendations for diagnosis of cerebral palsy, an overview of the clinical signs and key tools aiding detection of cerebral palsy, how we communicate with families, the family experience and key tips for clinicians, how we engage with Maori whānau, and also some new guidelines around respiratory health and hip surveillance. I'd like to acknowledge that this virtual education day is driven by the findings of the CAPTURE study, cerebral palsy, translating research on early identification. And we very gratefully acknowledge the Starship Foundation and the Athlete Lions Starship Trust for sponsoring this co-design work through the inaugural 2-year Athlete Lions Starship Research Award in early 2019. Athlete Lion, unfortunately, has passed away now, but she was one of the founding members of the Friends of Starship who fundraised in the 1990s to build the new Starship. She then became the inaugural chair of the Friends of Starship, and for many years was on the Starship Foundation Trust board. And we very much acknowledge the support of the Trust in the study and results we're presenting today. We'd also like to acknowledge our collaborating partners, health professionals and community members and people with lived experience of cerebral palsy across New Zealand who've honoured us with their work, shared their information and their experiences. So I thought just before we go into the main part of the day, it's sometimes useful to reflect on where we've been, and part of this is my own personal journey. Those of you who live in Auckland on the North Shore will recognise the picture on your right is Takapuna Grammar School, my high school. And across the road from Takapuna Grammar School was Wilson Home. Well, Wilson Centre is now known, but Wilson Home for the crippled children at that stage. And Wilson Centre in those days was set up to provide long-term residential care with children with polio and TB, but then began to provide care for children with cerebral palsy. And I recall at the age of about 13 or 14, going on a group visit across to the Wilson home, really to see the facility, and to meet the children who at that stage lived within the home. And I remember at the time it was really quite confronting, the thought that children with physical disability were living in a long-term residential care home. I didn't think that much about it at that stage, and I kind of moved on with life. And eventually trained as an orthopedic surgeon, came back to the orthopedic department in 1998, where I was told that I would be running some of the cerebral palsy service and I would be doing clinics at Wilson Home, which seemed like a little bit of a circle. And I circled from my teenage years through to my adult life. So this is our department in 1998. It's very different now in terms of diversity of the department members. And I think in the 1990s, what did we know about cerebral palsy? Well, we knew classifications, but we focused on impairment. We focused on parts of the body that were involved. We didn't know that. We knew a bit about spasticity, not much about dystonia. We kind of thought that everything was caused by things that happened at birth or pre-birth. And treatment, it was a little unclear how to manage, but usually orthopedic surgeons waited for fixed contracture to develop and then did surgeries to lengthen muscles. And it's very common to have long inpatient stays. But help was at hand. And in 1997, Palisano and al. Presented this really seminal paper about the development and reliability of the system to classify the gross motor function in children with cerebral palsy. And in their paper, they came up with 3 graphs. They had a graph of development of gross motor function in children without cerebral palsy, and then children who have mild, moderate, or severe cerebral palsy. But they quickly realized that that really wasn't enough to describe the abilities of children with cerebral palsy. So they came up with a 5-level classification system. And for the first time, we talked about functional ability rather than impairment. And we started to emphasize things that children could do in the home, the school, and the community. And we actually found that GMFCS was very predictive of orthopedic problems like hip subluxation. It's also very predictive of your risk of scoliosis. It's predictive of your outcome after certain surgeries. So therefore, suddenly we had a language we could actually talk about cerebral palsy that actually was relevant to the child, but also relevant to the clinician. At the same time, we came up with a new definition, and the definition emphasized activity limitation and emphasized that the musculoskeletal problems were really very secondary. So they weren't present at birth, but developed over time. And so by the 2000s, we were really focusing on how better to assess the musculoskeletal system, the problems, and how better to manage. We developed a Starship Gait Analysis service with the support of some support from the Starship Foundation to better assess the need for surgery. And we went on to appoint 2 rehabilitation physicians to support early spasticity management. But those things in the 2000s were really focused very much on the individual. And what we began to realize as we got into kind of 2010 and onwards, we really need to focus on collaboration. And really we've been focused in the last 10 years or so on 3 areas: health registers, multinational research studies, and the clinical network. And what we found, really, health registers take a population view, and they can look at group health outcomes in a way you can't look at them if you're looking at patient by patient. So this figure is from the Australian Cerebral Palsy Register. And what it shows is that for children who are neonatal survivors who are very low birth weight, there's been a huge improvement. Far fewer children are now getting cerebral palsy. So children are less than 1,000 grams in 1995, about 100 out of 1,000 would have cerebral palsy. Now, probably in 2010, only 50 out of 1,000 have cerebral palsy, a huge reduction. But possibly we're not doing so well in children who are higher birth weights, so particularly over 2,500 grams, the incidence of cerebral palsy is not really changed. So this type of stuff can really focus our attention on where we need to put efforts to improve outcomes for children with cerebral palsy. So we can use our health registers to monitor health outcomes, predict outcomes, but also monitor service delivery and useful in advocacy. So in 2015, we established the New Zealand Cerebral Palsy Register, and we're going to be speaking about that later. But this is really now has health information on probably about 1,400 children with cerebral palsy across New Zealand. And we're really working together with people with lived experience with CP, working together whānau, working together the CP Society to make this register something that can actually drive quality change in the care of children with cerebral palsy in New Zealand. We're also involved in multinational research collaborations with the Australasian Cerebral Palsy Clinical Trials Network. And Starship is one of the many partners in this research program. And this program is looking at how to implement early detection of cerebral palsy and really look at what is effective in terms of early rehabilitation. We also have now the Cerebral Palsy Clinical Network in partnership with the CP Society, looking at early identification, transition into adulthood, participation, and education. So those things all came about in really the last 10 years or so. But in 2013, I think we were really we were challenged by this paper by Iona Novak, a review of interventions for children with cerebral palsy, state of the evidence. And what this did was the traffic light system. And I'm sure some of you in the audience will be familiar with this. It caused a lot of consternation at the time because orthopedic surgery was put down into just over the worth it line, but not much evidence for it. And so there was some gnashing of teeth in the orthopedic circles about this. But this was actually a fair representation of the evidence in the literature. And then this is just more of the table. But basically that table, that has been updated in 2019 to look at early interventions. And I guess what came out of that study and the more recent paper by Iona Novak in 2017, that earlier detection of cerebral palsy is possible and earlier treatment is possible. And that's really been the driver for our capture study over the last 2 years and the driver for where we want to take the register and a driver for the CP Clinical Network, that we can no longer as doctors sit and wait for adverse outcomes to happen in the musculoskeletal system and elsewhere. We actually need to diagnose early and we need to have effective treatments early. So this is really the driver for the study and some of the work we're going to be presenting to you today. So I'd like to now hand over to the next speaker, Sian Williams.
Thank you. So this session, we're presenting some of our early findings on the current practice on the identification, early management, and some HIP surveillance data as well for cerebral palsy. So Sue has already briefly introduced some of this as our big capture study, which was thankfully funded by the Starship Foundation and the Athlay Lion Award as well. So we'd like to acknowledge them again. We should also note that this work has also been motivated by our wider involvement with the Australasian Cerebral Palsy Clinical Trials Network, which is a centre for research excellence and has a number of key themes and aims. And in particular, we focus on the early detection and neuroimaging aspects of that. And of course, as Sue also mentioned, this comes from this seminal work paper done by Iona Novak and colleagues, that called for this international shift in the approach to providing an earlier diagnosis of cerebral palsy, or at least identifying infants at risk or who may be under suspicion for cerebral palsy earlier. And a lot of this is centred around the evidence and the use and the timely use of key tools, including MRI, the General Movements Assessment, or the GMs, and the Hammersmith Infant Neurological Examination, or the HINE. So we'll be talking a lot about these three tools in particular today, and so you'll hear that coming up quite a few times. And of course, in addition to a lot more awareness now on some of our key clinical features that we need to be aware of to be able to prompt referral for diagnosis. So within this work by Iona Novak and colleagues, and since this work, there have been a number and many, many more studies that have come up that have focused on this topic. And this reflects a number of clinical and research teams all around the world that are working towards facilitating this shift towards earlier detection. So how are we working on this in ourselves in practice in New Zealand within our own context? And our team, that we determined that this first step would be to understand where we are at now in order to help shape where we need to be in the future. So we approached this from a number of different angles with a number of different sub-projects and activities where we set to capture that current practice, which is now past practice in a way. So current practice and awareness and the experiences, and even try to identify perhaps where any areas of major disparities may exist as well. So this included capturing the family perspective, some clinician awareness of tools and use of tools, a review of the clinical notes, which today also features a more in-depth look at the use of neuroimaging for diagnosis and also X-ray imaging for hip surveillance. And much of this information then all culminated in our co-design workshops as well, which really allowed us to reflect on the past and transform this information into the future. So, our family survey invited families to share their experiences regarding their child's diagnosis and early management. This survey allowed for anonymous single or multi-answer responses to set questions, but also included free text responses, which every one of our participants made use of. So we were very, very fortunate to get a lot more in-depth insights into their responses than rather just a yes, no, or I'm satisfied. So 57 families responded to our survey. The majority were mothers and most were coming from the North Island. Now the spread across the GMFCS levels is generally quite reflective of our proportions of our CP cohort in New Zealand, which is good just to give us a bit of an idea of our representation. But also it's really important here to just make note that a lot of these children, or the majority, are classified by GMFCS level 1 and 2. So when we reflect on this, on what that journey might be for their potential diagnosis pathway, this might well be that group who are more likely to perhaps experience some delays. So families were asked when they first noticed or first suspected their child might have cerebral palsy or a like condition or altered development, with 60% saying this to be before their child was 6 months of age. And when we were asked when their child was actually given their diagnosis, we saw this sort of quite a clear time lag occurring. And approximately half of our families actually said that they perceived a delay of more than 6 months, and 35% perceived a delay of more than 1 year. Now, I want you to keep this time lag in mind today throughout all of today's talks and reflect on what's happening for these families during this time, how they're feeling about their child's health, and what is that experience like for them. And when they know something might be up, but they're really still searching for those answers. So what we are quite pleased about to see was that almost half of our families said that their child's diagnosis was actually received under 12 months of age. So that's a really positive outcome. And we also saw a lot of really positive experiences being discussed by our families, with over half noting that they were satisfied with their diagnosis experience. When we looked further into our other aspects of their experience, we were also able to link outcomes of satisfaction with common themes, and one being the timing of the diagnosis. But beyond that was a huge value of communication and support in terms of navigating the health system and provision of information. So each of these themes will be very well interrelated as well. So for example, the amount and the type of information that they're given at the time of the actual diagnosis, but also how this was communicated at the time and along the whole journey of that process of getting to that diagnosis itself and what followed after. So we're going to be talking a lot more about communication in more detail this afternoon with Amy Hogan and Jimmy Chong in our communicating and reporting session. So I really encourage you to make sure you join in after lunch and take a moment. You'll see this pop up through the intermission slides, but take a moment to also complete our audience poll to hear your views on communicating about cerebral palsy. So you can also read the actual, these findings from this paper have actually been published and it's open access. So if you'd like to read more into more detail with it, it's open access, which means that anyone can download it. And you can also find a link to this paper on our Capture Study webpage on the Starship website. Now, moving over to the clinician perspective, our survey investigated the responders' awareness and use of assessment tools for the identification of CP. And this was obviously aimed at clinicians who would provide a diagnosis within their professional scope, but also who would have a major role in assessing or using these tools and refer these children for a diagnosis as well. So of our 158 clinicians responding, there was a slightly different line of questions for those who diagnose versus those who do not. But for both groups, we were trying to get a sense of how often they would use, what tools they would use and how often they would use them or refer for a diagnosis. So broadly reflecting on these results, it looks like whilst most of our clinicians will draw quite heavily on the clinical signs and symptoms and the clinical history, and they will use or refer to MRI. When it comes to the use of these other tools, in particular when we're looking at the HINE and the GMs, we're seeing there's not as much use in this cohort. And again, for our therapists, we still see quite a low uptake of these tools in being able to use these tools and maybe refer on for a confirmed diagnosis or entering along that pathway. And again, a really high reliance on that clinical signs and symptoms. When we looked into the reasons why the HINE and the GMs in particular weren't being used, most said it was because they weren't trained, but they also noted that there was a lack of familiarity with these resources or not having the resources themselves to conduct the assessments. And for the GMs, it was also noted that it wasn't necessarily supported that highly within their own workplace. Generally, when we look at barriers and enablers for change, a lot of those that were brought up within the survey focused on training and also changes needed within the team and management level to help support within their workplace. On top of this, we had over half of our clinicians actually indicating that their workplace didn't have any standard guidelines or procedures that to guide them in referring a child for diagnosis or for that early detection. And 98% felt that they agreed that there would be a consensus approach would be very helpful in their practice. So again, full outcomes of this paper have been published and the link again can be found on our Capture webpage. So we've heard from our family and clinician survey. We've got a little bit of an idea of where we're at for now. We're going to actually move you over to Mackey now to talk us through all her very hard work that she's done on our clinical notes audit for use. So thank you, Anna.
Okay, thank you very much, Sian. Kia ora koutou. My name's Anna Mackey, so I've been working on this project and also I work on the New Zealand Cerebral Palsy Registry. So just as the next couple of talks are to do with the registry, I've just put up a slide here to introduce you to what it is. So it's a confidential database we have of health information related to people with CP, and it's open to everybody. You can see on the right there are our aims at the moment, and we're also under a current sort of redesign or regeneration, and that's some work we're doing with Dr. Karen Wright, who's going to be speaking later today about how we can address some more pertinent issues that are happening in the New Zealand health system. So for the purpose of this study, we did an audit basically of participants on the registry to look and describe what CP looks like in New Zealand, but also using some of our variable data from the registry that we can perhaps look at the diagnostic process further. We also wanted to assess the potential for any inequity between Māori and non-Māori tamariki. So we included children who were born in New Zealand from the registry, who were on the registry, who were born in New Zealand over the last 10 years, and this was to keep it current. We did require a minimum amount of information or data set on our registry or access to that via DHB. So that left us with 8 DHBs, and we extracted information from 277 participants on the variables of interest. So from that cohort, we had 30% were Māori, that's 83 individuals, and 70% were non-Māori. So these are the variables that we looked at. Firstly, demographics. So the registry uses the NHI to link with the Ministry of Health to gain information on prioritised ethnicity, and also something called the New Zealand Deprivation Index, which is documented there. It's a reflection of a dimension of deprivation applied to geographical regions around New Zealand. So quintiles 1 and 2 represent the least deprived regions, and 4 and 5 represent the most deprived regions. We looked at birth history variables and also clinical variables. So the demographic findings, consistent with cerebral palsy populations around the world, there's a predominance of male in our cohort. Where people were from was predominantly the Auckland, Hamilton, Wellington region, so we had about a 90% city spread. When we look at the findings of our deprivation index, unfortunately this reflects what is New Zealand society, and that the Māori cohort in our population, 60% of them were living in the most deprived regions, quintiles 4 and 5, compared to 40% of non-Māori. And we know that these social determinants of health impact on health considerably, at which we perhaps are not picking up in our static registry, but do come later. Registries look or classify children with cerebral palsy in terms of the timing of when the possible cause is. So for this talk today, I'm just going to be talking about the 90% nearly who the potential cause was a pre or perinatal event, so happening either throughout pregnancy or during the first 28 days of life. And as an aside, we see that 5% of that cohort come under ACC coverage here. As you can see, it's nearly 70% for those that have a potential postnatal cause. So our birth history findings. We know that preterm birth and low birth weight are both risk factors for cerebral palsy. So we found that 57% of our cohort were born at term. And the bottom wheel down here represents the gestational age broken up. And so that 43% who were preterm as well. So interestingly, this distribution perfectly matched nearly the Australian Cerebral Palsy Registry data set. And this is our gold standard, as it's a population-based data set. We also found a similar matching in our birth weight profile. So less than 2,500 grams is low birth weight. And we can see 43% of our cohort fitted into that, which again matches with Australia. We found 65%, or nearly 2/3, had spent time in the neonatal or special care baby unit. So the timing of the initial CP description, and this is where it really, we thought, relates to what a CP diagnosis is given. So this is universally used through CP registries. As it's not an exact science, it's taken when the first time cerebral palsy is described in the medical records. So for our cohort, we found that 38% of them had got that diagnosis in the first 12 months of life. And 75% had it by 2 years of age, with the average age of a diagnosis coming at 19 months. This compares with the Australian registry below, you can see. So 50% in Australia had their diagnosis by 12 months, and then similar to us, 75 by age 2. There was no difference between Māori and non-Māori. And also the average diagnostic age of 19 months is also very similar across overseas data as well. So I think that earlier shift here in Australia that we see there is perhaps an area for change, although we do know Australians have a different health system and needs, which is also probably a driver for that. The service giving the diagnosis is not unexpected. It's coming majority from our paediatricians, and you can see some impact of the Auckland cohort with developmental paediatricians and neurologists also having a role. The pathway to a CP diagnosis is really variable, and we know this because we have a heterogeneous population we deal with. So I've just highlighted here some of the impacts that were on it that influenced the timing. So we can see the presence of epilepsy or a difficult birth, neonatal encephalopathy, brought a lower than average timing of diagnosis. For that 2/3 that spent time in the neonatal unit, we can see they're about average in their timing of diagnosis. When we break it down by gestational age, we see it's quite interesting that those that are under 28 weeks come out with a later timing of their diagnosis. I mean, anecdotally, I'll just say it's probably that this group, their diagnosis is often referred to as their gestational age for up to 2 years. They're called an X26 weeker, an X24 weeker, and it's not until they hit the paediatric system that often the terminology of cerebral palsy is discussed and written in the medical records. This final group down here is the one coming through primary care. So it's often a delayed milestones being detected by well child or family. They made up about 11 or 12% of our cohort. The other influences on diagnosis were GMFCS, which is shown here. So more severity in your function, they had an earlier timing of diagnosis compared to GMFCS1. There was also an impact on the DHB you were in as well, which is probably influenced by all of these number of variables. So clinical descriptions of our cohort. So Sue described the gross motor function classification system, which is listed here, with levels 1 and 2 being those that are independently mobile, with 4 and 5 with more dependent mobility. So this again, this wheel or profile matches what we see in an Australian population and overseas registries, which is reassuring, with 2/3 nearly of our population having independent walking mobility. The topography or the motor type, again, is very similar with what we see overseas, predominantly spasticity, with diplegic and quadriplegic combined, giving 53% of the distribution. For those where we had ability to look at upper limb function, so a classification measure called the manual ability classification, we saw that nearly 3/4 have independent upper limb function. This is a brief overview of the comorbidities that we saw in the population. So 40% of our cohort have or had epilepsy. This is slightly higher than what we see from overseas, where usually it's around 30%. And here is just a brief summary of the visual, hearing and communication impairments, or this is abilities that we see. So 60% have no impairment in visual, 85% have no hearing impairment, and 80% can communicate verbally. However, the traditional measures of questions that we use in registries around this are quite poor and simple. So we're actually really trying to shift towards using these classification systems that Sue alluded to as well. So we've put together a poster combining some of this information, which is now available on the Kids Health and Starship webpage. So it includes not only gross motor function, there's communication, eating and drinking, and visual function classifications. We had a look at how much the terminology is being used in our medical records, and you can see the percent of the cohort that had this information there or could be inferred. So we often infer a GMFCS if it's not present, but predominantly it is there in the medical records. So there's room for improvement here. Just briefly, surveillance and imaging. So the registry collects the timing of their first hip x-ray. We saw that nearly 3/4 have had a first x-ray in the first 2 years of life. However, we did find a difference in the median age between Māori and non-Māori, although this was not significant with the great variability there. We also look at cranial imaging, and at the moment, that's just whether you've had one or you haven't. So we can say that nearly 90% had an MRI by age 5, and we are moving to a more detailed classification system now. Of interest, we saw a downward trend in the timing of this MR. So the earlier birth years, it was a little bit later to what it is now, and this potentially is due to access to the resource has changed over the last 10 years. So very briefly, we were able to look at the service impact only really for the Auckland region, as New Zealand doesn't have a standardised outpatient coding system, which makes looking at these things very difficult. So, but as we would expect, we see that families are in contact with up to 30 different distinct hospital services by the age of 5. And this is across all GMFCS levels, with the most frequent ones listed below. I think this was interesting in terms of audiology and ophthalmology, which probably reflects our NICU cohort that are being referred on to those very early on. I also found it of interest that nearly a third are going through the dental service at tertiary level and a quarter through the cardiac service as well. So in summary, there were concerning levels of social deprivation for Māori tamariki with CP, and this does reflect New Zealand society. However, I think for disability is that added factor. And so we as a register are trying to action this and feel that it's a priority now to try and collect good data for Māori with cerebral palsy, and your guidance and help on this would be invaluable. In terms of diagnostics ability, I've listed some findings that we have here. I think one of the key findings was that the neonatal service is a first contact for up to 65% of our cohort. And so we're going to hand over now to Dr. Malcolm Battin, who did a more in-depth look at the neonatal service and share his findings. Thank you for your time.
Well, Morena, good morning. It's nice to have had the introduction talking about the importance of neonatal care going forwards and the consequences in neurodevelopmental outcomes. I'm going to talk about the neuroimaging in NICU graduates who subsequently developed cerebral palsy, and I'd like to acknowledge the research team as listed there, and also the foundation and the cerebral palsy register. By way of background and context to this, we've heard about the importance of imaging in clinical assessments for the early detection of cerebral palsy. And I'm not going to reiterate or duplicate what's been said previously, but I'm going to say that this is relatively recent work over the last 5 years, with the Novak paper in particular being published in 2017. And I think that's really important in terms of context of the findings from today. I'm also going to say that overseas, we've had experience of a number of guidelines and practice documents that have helped assist in bringing down the age of cerebral palsy diagnosis. And after coffee, we're going to hear about New Zealand documents that will go forward from that. But what I'd like to do is take a step backwards and do a stock take of the current neuroimaging practice within the NICU, because I think this is really going to be useful and important going forwards in implementation of these practice documents and best practice guidelines. And it will help us to understand some of the facilitators, the way that the system works, and some of the barriers, but also the yield of the current imaging and the opportunities for new approaches that could be in terms of imaging, which we know is a limited resource, or the use of other assessments, and to try and make a joined up assessment. So the aim today is first off to review the frequency and modality of neuroimaging for high-risk infants. There's going to be a sub-analysis of this by gestation and also by ethnicity to ensure that we get equal access. They're going to benchmark these against available guidelines, and there aren't that many available published guidelines around this, but we're going to benchmark them against expectations. And then we're going to look at the rate of abnormality in each of these individual groups and the relationship with subsequent cerebral palsy. So this cohort was identified from the New Zealand Cerebral Palsy Register, and I would really like to shout out about how useful this is as a resource going forward for this sort of important clinical work. It's a very valuable resource. The children were all born between 2000 and 2019 inclusive. That's a wider timeline than with Anna's work, and what we wanted to do is to get a reasonable number of individuals. So this 20-year epoch was chosen, and I think it's going to be reasonably representative in the imaging that's used during that time. The analysis is going to be by 3 predefined gestational age bands. The very preterm infants who are born less than 32 weeks, or extremely premature infants born before 28 weeks. Moderate to late preterm infants between 32 and 36 weeks, and term infants. And I appreciate that not everybody works in NICU. These are the old slides, Sian, not the new ones. Down the bottom of here, and there's a NICU guide to imaging of what's used. So I put that in because I appreciate that not everybody is going to be totally familiar with NICU. For the very preterm infants, they're going to be babies who are receiving level 3 or neonatal intensive care, and they're going to have ultrasound scans as a routine on day 5, 28, and 36 weeks. The moderate infants will typically receive an ultrasound scan. They may occasionally receive MRI scan, but these are all on the individual case basis. They're not on a set program of imaging. And then for a term infant, and the term's dropped off here, there's going to be an MRI for babies who've got a neonatal encephalopathy. That's a consensus guideline. But all other conditions are really on an individual case basis. And then the second analysis is going to be by ethnicity, which I think is very valuable and important. So this is our study cohort of 140 individuals. The median gestational age is 33 weeks, but more importantly, the span is here from 23 weeks up to 42 weeks. Similarly, median birth weight is just under 2 kilos, but from 700 grams right up to over 5 kilos at birth. And the length of stay, LOS, in NICU is about 30 days, but ranges from 1 to 189 days. And so that's a considerable period of time for some of our most immature infants. When we look at ethnicity, the most common group is going to be the New Zealand European at about 55%, going up to another 7% for other European groups. But we do have a 16% Maori and 13% Pacific within this population, so we're able to look at those groups as well. And then a smaller number of Indian and Asian families. When we look at cerebral palsy, we've talked a little bit about the topography before. This is the classification at 5 years of age and going forward. Some of the infants will be appearing on the register before 5 years, but I've used the 5-year data. And as previously said, there's the largest group is the diplegia, 37%, 29% for quadriplegia, and then 16 and 12% for the hemiplegias, and smaller numbers of other manifestations there. And then, as also been discussed before, the gross motor function is going to be higher in the levels 1 and 2, with smaller numbers in the other groups. So that's the whole group. What I've done here is divide them up into their individual gestational age groups. The extremely or very premature infants, less than 32 weeks, there's 55 of those. Mean age of 27.9 weeks, 1,200 grams, and a length of stay of about 70 days, going up to, as we said before, quite considerably more than that. For the moderate preterm infants, there's relatively smaller number, just 34 of those infants. The mean gestation and birth weight are given there, and their stay would be about a month in NICU. And then the term infants, mean of 39 weeks, just over 3 kilos, and stay would be about 18 days on average. Next thing to think about this is this gross motor function classification. And for the extremely premature or the moderately premature, about 2/3 of those are going to be in the milder groups, the 1 to 2. For the term infants, there's more of a spread between the milder levels 1 to 2 and more severe grades. And the numbers don't add up to 100 because some of those babies, children, haven't received their 5-year-old classification at this point. Going to move on to the imaging, again, split by the 3 individual gestational groups. For the less than 32 weeks, the number of children in that group is the yellow bar, and then the teal bar is the number who've received imaging in the NICU. And there's a very high level of imaging, 96%. Then we see for the moderately premature group, just over 30 babies, and about 56% of those have received imaging. And then in the term infants, over 50 of those, and 82% have received imaging. In the black bar, we show how many of those have an abnormal result as reported. And you can see in the very premature group with the high level of imaging, about half of those are reported to be abnormal. And I'll give you a little bit more granularity about that later. For the term infants, only one infant was reported to have normal appearances on MRI. All the others were abnormal. And then for the moderate group, 68%, so a little bit between the two, were graded as being abnormal. So thinking about this and benchmarking against practice guidelines and recommendations, 100% of our term infants with a neonatal encephalopathy, that's what NE stands for, completed and had an MRI. Overall, there was just over 80% imaged, but there's only one document that guides the imaging, and that's for neonatal encephalopathy. All the other conditions are under a case-by-case basis. Similarly, for preterm infants, we're 100% in accordance with our paradigm, our practice guideline of less than 30 weeks or 1250 grams. There are few numbers of babies between 30 weeks and 32 weeks who didn't qualify for imaging, but we complied with the guideline 100% with these babies, which shows we're able to follow guidelines when they're there. We do, however, know that the ultrasound is less sensitive than an MRI, and we commented here that 53% of them reported to have abnormal imaging, but often this was only at mild or moderate degree. It wasn't severe. And 87% of the infants less than 32 weeks without a severe abnormality were graded in that gross motor function 1 or 2, so consistent with the milder end of the spectrum. When we're looking at cerebral palsy topography by gestation, the blue is the extremely premature, very premature, the red is the moderate, and the green is the term babies. And you can see that diplegia is seen much more frequently in the preterm infants. And even the small number of term infants who had a diplegia as their manifestation showed this white matter abnormality. There's more of a spread with quadriplegia and again with hemiplegia. Shifting to analysis by ethnic group now, I've given the data here for the percentage who were imaged in the NICU across the 3 largest groups, New Zealand, European, Maori, and Pacific, and then the percentage had abnormal imaging. And you can see there's a high percentage with abnormal imaging there. When we look at these by both the portion imaged and the rate of abnormality, there's no statistical difference between these 3 groups. Numbers are too small to start to cut that again by gestation, so I've just left it at that level. Moving on now to the term infants who've received an MRI, and this is the Himmelman classification system, and I just wanted to introduce this here. It's a simple, easy to follow classification for MRI in this sort of situation. And we start off with maldevelopments as the first category, and 1/4 of the infants in our term study cohort had maldevelopments, often cortical malformation, but also other things such as standing Walker or holoprasencephaly or hemimegancephaly. The predominant white matter injury is seen more typically in the premature infants, and I didn't have enough numbers to really give detail about that for babies receiving an MRI. Most of this was from ultrasound. When we look at the predominant grey matter injury, 2/3 of our term infants came under this category. Basal ganglia and thalamic injury was common with hypoxic ischemic injury, and then arterial infarctions, middle cerebral stroke type manifestations in about 10 or 12%. And then the other groups are miscellaneous and normal. So I'm going to use all this information and come up with a few areas where I think we could develop our service and we could think about things. Certainly from the numbers of babies receiving imaging at 32 to 36 weeks, there could be an opportunity to increase the numbers of babies who receive imaging. This should be informed by a guideline and some selection criteria, because the number of babies born in this age group is much higher than the extremely premature infants. And I think there's work in this in the literature, but at this stage, there's no document that's set out to guide that for our New Zealand babies. I think also we should work on developing criteria for an MRI at term for the babies who are born at less than 30 weeks gestation and receive a series of ultrasounds. And just try and work out the best return for that, because we all recognize that MRI is a limited resource. And there's been recent publications by David Edwards and etc. saying that they don't think every baby born less than 30 weeks should receive an MRI in that regard. Then I think we could do work on reporting our findings on MRI in a standard framework as published by Himmelman. That would really help in terms of communication. It would help with communication with families. It would help with communication between services and between hospitals. It would also assist with interpretation of imaging from people who are being seen outside the tertiary centres, and it helps with the standardisation of the record. And of course, all of this work and discussion of the findings has to take place with parents and whānau, and it should be done in NICU prior to a transfer or discharge from the unit. So I think there's plenty of areas for us to address and to look at in our practice going forward. And I'd like to end by saying thanks particularly to the Starship Foundation for supporting doing some of this work, the Cerebral Palsy Register that I've already mentioned, and HRC that funds some of my clinical research, but also the children and their families and the rest of the research team. So thank you very much.
Kia ora, I'd like to thank you for the opportunity. This is the first opportunity I've had to present the findings of a research project we did entitled Hip Surveillance Practice in the Tertiary Hospital Setting. I would really like to start by thanking the Wilson and Sweet Fellowship. Am I too short? The Wilson and Sweet Fellowship that supported this research and enabled the completion of my master's degree, and Sue Stott for her incredible supervision during what turned out to be a very, very disruptive and challenging year. And of course, my very patient colleagues, Anna and Warud. Oh, sorry, it should have been that screen. So just some background. We know that neuromuscular hip dysplasia is the second most common secondary musculoskeletal consequence of cerebral palsy, and it will affect over a third of children that have a diagnosis of CP. If it's left undetected, it can progress to complete hip dislocation. There is great variation in the literature, but we do know that those with GMSCS 4 and 5, classified as GMSCS 4 and 5, will complete about 50 to 90%, depending on what paper you read, will progress to complete hip dislocation. And this can cause pain and functional limitations right into adulthood. We know that that a sustained focus of radiographic surveillance can prevent the advancement of secondary neuromuscular hip dysplasia, but it also can prevent hip dislocation. And as a result, a number of international guidelines have been developed to determine the timing and the frequency of each GMSCS classification at which this should take place. So, the aims of our overall study was to understand clinical practice around hip surveillance and the use of guidelines for children with cerebral palsy living in the Auckland and Waitemata DHB regions. And we used all of this data to retrospectively benchmark key findings against international guidelines for hip surveillance. So our methodology was broken into three parts. We first, to determine clinical practice, sent out an electronic survey, and that was distributed through membership of professional membership bodies and societies. We also then collected data, and we did this by extracting a cohort from the New Zealand Cerebral Palsy Register for birth years 2008 to 2018. And the inclusion criteria is that they had to reside in the Waitemata and Auckland District Health Board regions for the first 5 years of life. And using that NHI, we then linked that retrospectively to radiological and first specialist appointment databases that were held within the DHB. And then we extracted the radiology reports from the medical notes, and we extracted some data from those too. We then went on to benchmark all key outcomes. So the key outcomes were the timing of hip x-rays, and the outcomes were then mapped across GMFCS levels, which enabled benchmarking against hip surveillance guidelines to determine if current practice met any of the guideline recommendations. And just for brevity today and from the time constraints, I do have to acknowledge that I know a number of you in the audience did participate in the survey, and I do acknowledge you and thank you for that. But there was such rich data from that, I don't have time to discuss that in detail today. So we'll find another forum for that. In terms of our demographics from the CP register cohort, we had 164 participants that were extracted. We included 159 for analysis. The ones that were excluded is because they didn't spend enough time in the first 5 years of life living in the DHB. And our median age of diagnosis, documented diagnosis, as Anna has described, how we collect that information, was 18 months. I will refer to the ACPR report in terms of comparing our cohort to the ACPR findings, and we found that we were kind of top heavy in towards our males, with slightly more males than we would expect. We were also quite low on the unilateral, so a lot of 28% of children were classified as hemiplegia, whereas we'd expect that to be around about the 40% mark. We also had about 33% were classified as diplegia, and 33% were quadriplegia or triplegia, and the remaining were either hypertonia or a movement disorder as a primary diagnosis. However, our GMFCS was around about what we expect, so 60% of children were independently ambulatory, and the remaining were 3s, 4s and 5s. In terms of our ethnicity, so the distribution of the ethnicity was around about what we would expect for these two DHB populations, except we did find that our Māori population across the two DHBs is about 10%, and in our cohort we had 20% were Māori, identified as Māori. So when we take a look at the distribution of GMFCS across ethnicity, more European children, which are depicted by the orange bar, were classified as GMFCS 1 and 2, whilst more Māori children, depicted by this yellow bar, were classified as GMFCS 4. Whilst this was not statistically significant across GMFCS, when we started to group GMFCS together, we did find a statistically significant difference, and I will talk about that a little bit later. For deprivation, as Anna has alluded to, we used the New Zealand Deprivation Index of 2013, and this was linked to the NHI. Of interest, those that were grouped as non-independently ambulatory, in other words, those with greater severity of with GMFCS 1, 3, 4 and 5 were actually living in areas of highest deprivation. So quintile 5 is the green, and you can see that they live in, are dominant in this area. So when we started to look at the timing of hip x-rays, we collected all our x-ray data, we determined that 6% of our cohort had never had an x-ray, that 26% had an x-ray before they were diagnosed, and 70% had an x-ray after they were diagnosed. So having a quick closer look at this, the characteristics of these three groups, it shows us that those that never had an x-ray, so that's 6%, had a comparatively very late diagnosis. They were all either hemiplegic or diplegic, and they were all GMFCS 1 or 2. So the description of CP and GMFCS distribution were very similar for the two remaining groups, but the age of diagnosis here was noticeably different. Those having a hip x-ray diagnosis before they were diagnosed with CP 12 months, so this group would diagnose 12 months later than the group receiving the x-ray after their diagnosis. This difference may be a reflection of hip x-ray being used as part of the diagnostic workup. So simple regression analysis identified GMFCS as being one of the variables of significance in terms of the timing of first hip x-ray. This trend is really what we want to see with children classified as GMFCS 5, having their hip x-ray about 11 months earlier than those classified as GMFCS 1. And particularly when we put that into context of what we know about risk of hip displacement. But the question is this early enough? Is that median age of 18 months early enough? And the answer is probably no. And I will give an explanation for this when you start to look at the benchmarking exercise and the number of GMFCS children falling outside of that median age. So we collected data for up to 4 x-rays for each participant where it was available. And on this graph is quite aesthetically pleasing in terms of colours. It also shows this encouraging trend across radiographic surveillance, with GMFCS 5 having their first hip x-ray at a median age of 18 months and those of GMFCS 1 at 29 months. So we can see that there. We also encouragingly see that the GMFCS4 and 5, actually the interval between X-rays is a lot shorter than that of GMFCS1 or 2. So by the time GMFCS1s or 2s were having their third X-ray, the GMFCS4s and 5s had completed up to 4 X-rays by that time. So I'm putting this graph up now, but this will be a key visual when we're discussing benchmarking and the timings of first and subsequent X-rays later on. So what did we find when we looked at the radiology reports? So in terms of the RMP, now the RMP is the gold standard measure for measuring hip displacement, and it is used in hip surveillance guidelines to determine recommendations based on measurement. For example, if an RMP is greater than 30, then that would trigger a referral to orthopedics. So it's quite key to hip surveillance guidelines. And we see that only 10% of RMP was reported in the first hip X-ray in all the reports, but if it was reported initially, it continued to be reported. So what was preferred was more descriptive terminology in terms of describing the acetabular angle, whether or not the femoral head was inlocated into the acetabulum, whether it was aligned with the acetabulum, or whether there was coverage of the acetabulum. And often that was used, there was other descriptions like whether that was subluxed or dislocated or dysplasia. And those two were usually accompanied together. So because of this, because of the lack of the RMP, it was really difficult to define what was an abnormal hip X-ray. So that made it quite challenging. And we did use some strong methodology on grouping kind of those descriptions and what would be described as being an X-ray of concern or an abnormal X-ray. And I won't go into that too much detail now. And I would just like to highlight that we didn't go back retrospectively and measure the RMP. It was purely based on the reports. So we can see that for the first X-ray, there was a 10% incidence of an abnormal X-ray out of the 149 children that had their first hip X-ray done. And on average, there is a 6% incidence of an abnormal X-ray across surveillance. And it's worth, particularly in the second, third, and fourth X-ray, those were all GMFCS4 or 5. So what are the risk factors in clinical practice that contribute to presenting with an abnormal hip X-ray? So we found that those who had a diagnosis greater than 24 months had a risk factor of odds ratio of 2.7, although not quite statistically significant, almost there. And those that had a delayed first hip X-ray of greater than 4 months from diagnosis had a really significant increased risk of presenting with an abnormal first hip X-ray, almost 6 times. And just quickly to discuss the timing of referral to orthopedics from an abnormally, from an X-ray that was identified as abnormal, that timing from referral was 2 months, and then to actually being seen by orthopedics was 3 months. So that time was it's about 5 months from, on average, between identifying an abnormal hip X-ray to being seen by pediatric orthopedics. So we did not set out, and I didn't have an hypothesis around inequity. It wasn't an aim or a question that we had included in our research. But as we were looking at the data, it became glaringly obvious that there were differences that we couldn't ignore. So although 30 out of 32 of Māori children had their first hip X-ray, the median age of diagnosis wasn't found to be significantly different for Māori children being diagnosed at 18 months compared to 15 months. And also the median timing of their first hip X-ray for Māori being 18 months and non-Māori 21 months was actually not significant either. However, they were more likely to present with an abnormal first hip X-ray. They were also more likely to be living in areas of greater deprivation, and that was not too dissimilar from the findings from Anna's cohort, particularly when we compared quintile 1 and quintile 5. And they were also more likely to be non-independently ambulatory. So in other words, have greater severity of CP. So we're setting the scene for benchmarking. We've collected all our data, and this is quite a nice depiction of kind of the data we collected around X-rays. But what really becomes significant is the timing of the X-ray. So we have here the diagnosis of 9 months, and the timing between diagnosis and the first X-ray was 9 months. The second timing at 27 months, that gives us an interval of 9 months and 7 months and 8 months. And it's the timing that becomes significant. And we can see even at this interval, apologies, this is just an example for GMFCS5. I won't go through every benchmarking for every level, but this was a collection, all of our cohort for GMFCS5, we did this process for, but this is just an example of GMFCS5. So we can see that despite we having this timing, which appears to be quite nicely spaced together, we're still having quite high incidence of abnormal hip X-rays, although it is declining. So we did a literature search just to make sure that we captured all the international hip surveillance guidelines. But in this session, I will only talk about the Australian hip surveillance guidelines. And because this was reported to be used universally across, from a survey in areas that were actually using hip surveillance guidelines in practice, it was the Australian hip surveillance guidelines that were being used. So we'll talk about the Australian hip surveillance guidelines. And of course, we can't not but talk about CPUP, the Swedish model, which are obviously pioneers in this field of hip surveillance. And I do apologize, this is a very busy slide, but I soon found out that benchmarking is a very visual thing, and I soon ran out of floor and wall space in trying to match and benchmark all 5 guidelines. So it is very busy, but bear with me. So in our first column, we have GMFCS, and the second is the timing, which I described in the previous slide for each GMFCS level. So that for this, this slide is just about the first and second X-ray. And then third is the Australian, what their recommendations are for timing of those X-rays and whether or not our cohort for each group met the percentage that met the timing of first hip X-ray and whether or not they met the recommendations for follow-up X-ray. I hope that makes sense. I wish I could see an audience that were nodding or not. But for brevity's sake, I'm just going to talk about 4s and 5s. So we can see that only 3/4 of our cohort under the Australian hip surveillance guideline met the recommendations to have their first hip X-ray within 24 months with the age of diagnosis. And the same was for the CPUP. Only 3/4 of 4s and 5s met that initial recommendation for timing of first hip X-ray. The follow-up is different. The recommendation for the Australian hip surveillance guidelines was 6 months, and our cohort did not meet that recommendation, as we saw in the previous slide. The timing was on average about 8 or 9 months. And then we did meet CPUP guidelines because it was a 12-month recommendation for follow-up X-ray. And in light of the fact that we're still seeing abnormal X-rays at a much smaller interval than 12 months, it's, you know, it's important to consider, is this good enough in terms of timing of X-rays? Oh, and just to say as well, sorry, that this was based on the 2014 hip surveillance guidelines, and this afternoon we'll be hearing from Pam Thomas, and there is a significant update which will really change this cohort here in terms of what those outcomes might be. So I think in conclusion, I think there is definitely an opportunity to change clinical practice to reduce the incidence of advanced neuromuscular hip dysplasia and hip dislocation from 6 to 0. And that sustained focus has been demonstrated in Sweden. And the things that we can change is that early identification of CP, because we know that once children have been identified as having CP or have a diagnosis of CP, they are definitely on a surveillance pathway and not delaying that first hip X-ray from having a diagnosis. And we do know that current practice is not meeting the needs of Māori children. We really do need to understand the experience and their family's understanding of surveillance to empower them. And this is probably a first step to start what is an enormous task of creating system change and tipping that inequitable balance. And I'll leave you with a slide. Again, another plug for registers, but this is a very powerful statement from Nadia Badawi, who is an advocate for registers. But we have seen that registers have supported all this research this morning, but there is so much more potential. And more can be done in terms of making us a population-based register. So thank you very much for your time, and I'll hand up to Sian.
So in our final few minutes, I'm going to talk about just some of our learnings from our co-design workshops, which again, thanks to the Athlay Lyon Starship Clinical Research Award, allowed us to seek the expertise and skills of the Good Health Design team to help facilitate these sessions. I'd also really like to acknowledge the help from Tina Battin, who guided the running workshops for our Maori whānau in the Waikato region, and Meg Smith and Tanya Johnston for their help with our recruitment for those, for finding our families and clinicians as well. They were brilliant help. Now, unfortunately, whilst we don't have time to talk about all through the processes of how we ran the co-design and what's involved in how the sessions themselves run using these fancy design elements, if you are interested in hearing more about how they're run, you can hear Ivana talk in more detail on our Starship Wednesday paediatric update presentation that we ran not too long ago on the Starship website. But essentially, when we're using a co-design approach, we're really seeking to elevate that lived experience through an active and equal partnership of families and clinicians working together in the same room, in the same space. So we held 4 workshops, 2 in Auckland and 2 for specifically trying to focus for Maori whānau in Waikato, with the first workshop series always being about the discovery of the topic, and then the second being about the prototyping for solutions. So each workshop had a balance of parents and clinicians in the room. And now, though the numbers here on the screen might look a little bit skewed, the majority of our parents actually attended both sessions. Even if they initially indicated that they would only be able to attend the first one, we did have some families quickly reshuffle their schedules and get more babysitting in so that they could attend the second follow-up session. And we're very mindful of really creating this balance in the room, or rather almost a power imbalance towards favouring those families so that they felt really comfortable to share in that space. And the Good Health Design team were really fantastic in breaking down any barriers and really facilitating these conversations through different sort of design-led activities that were well beyond my skill sets. Just for some impressions, a little bit of the co-design processes though, there was really such an eagerness and almost a thirst for these, for people to share their stories and share their experiences. And in speaking to some of these families after the sessions, they told me about how empowered they felt being a part of this process, which was really poignant for me to hear and see that. I imagine as clinicians, it would have actually felt quite a confronting process at times. And so I really want to acknowledge them again, and of course, as well as our families, but the clinicians for taking the time here, because it could have been quite difficult. But overall, I believe the impressions were, again, that they felt it was quite a positive experience to be a part of and a learning point for them. So every family's stories and experience and journeys are really unique and varied, and we have to, of course, acknowledge that. But what really resonated with me was actually there's so many similarities that were popping up between what we heard here and what we've learned from our previous studies in our survey, for example, but also stories that we hear from families outside of our research as well, and even across the globe as well, on these feelings, thoughts and needs around that diagnosis journey and early management for cerebral palsy. So families shared common feelings of shock, feeling isolated, betrayed and uncertainty in those early experiences. And few really understood what cerebral palsy was and what that actually meant for their child. So this would really start the beginning of their information seeking journey for their child and for their family as well. This is really important for us to keep in mind in that first stages. A lot was talked about in relation to the timing of when to communicate that diagnosis and when to start sharing some information that cerebral palsy might be a possibility for their child. And again, a lot of this came down to it just being a really open and honest process that they were seeking. Even if the clinician might not necessarily be certain just yet, having that information or that suspected or suspicion early on in the process was highly valued, especially in favour of some of how the families felt when they accidentally found out about their child's diagnosis through appointment letters or through another medical professional who made an assumption that they already knew. And it was felt that information was not always communicated or conveyed to whānau, sometimes perhaps due to lack of time, reluctance of clinicians to verbalise that possibility of a diagnosis. And health professionals really reflected as well on how perhaps it was important not to make those assumptions and communicate with the family to see where they're at in their process and perhaps guide them in their questioning and in their understanding as well. There's a lot to learn. And again, so much of this comes down to providing information for those families and enabling families to find the right information, access it, and also understand it at the right pace for them, which is no small task, because obviously everyone's so varied, and it's very varied to see when everyone's ready for that information to be shared. In concern for inequity of healthcare, a point was made about how parents almost need to be that advocate for their child, but not all parents are in that position to be that advocate. So a large part of, again, in a health professional role in the health system, that information sharing is also about empowering families to be that advocate as well. And so solutions will discuss about how an information pack of sorts, for example, might be needed to help that process. And families, it might allow families to share and discuss their condition with their healthcare team, enable them to document their journey over time and build their own insight into better management of their child's condition. And also this would potentially help clinicians to better understand what matters most to the families at that time, including their context and of course their emotional needs. Navigating the healthcare system came up a lot, and receiving support through this time was also a really key issue for families. And clinicians also really acknowledged how complex and sometimes unclear the pathways are. So it was discussed about what was needed was perhaps a clearer, if possible, a service map to help with coordination of service and all the appointments and all the different teams. So the idea of a navigator or a health coordinator was brought up in both of our regions and something that would be needed or would be appreciated. And this would help serve as a mediator, communicating with the system, and also convey information for the family as well. So dreaming and thinking big when we're planning these sort of potential solutions, this came down to working together, supporting spiritual and emotional wellbeing, and enable equitable access through different modes of information sharing. And this could be some sort of a regional hub for children with cerebral palsy. And this sort of hub could have coordinated appointments, the teams all together, communication is clear between the teams, and again, much talk about information sharing and packs and navigation through that time. So again, talks about those clearer pathways for different stages of that transition as well, so not just in that diagnosis point, and wellbeing support and involvement of whānau throughout each step. And it was proposed that in those first visits, there would be a service that provides emotional support and information for families to take home. So that can focus on providing information on more about what cerebral palsy is and the different potential aspects of how the presentation might be for their child and how that could be different. So information that might be presented in a gradual way, so not to completely overwhelm them, but also can cover strengths as well. So for example, a child may be in a wheelchair if that's what their prognosis might be looking like, but they'll be able to do many things. So really highlighting that strength as well. And there's also value that discussed about using careful use of key terminology here as well. Parents, some little final take-home bits that parents need to be told to bring a support person to their appointment, that first appointment, acknowledging the family whānau experience and not have that open willingness to engage in discussions on other potential treatments was discussed. Again, celebrating our strengths and using these cerebral palsy specific terminology. And as Anna mentioned before, we have provided we've started off some resources that you can see on the screen, and you can access them online. And part of this was because there was such this discussion about not knowing what cerebral palsy was, or not knowing what the range of cerebral palsy could look like. And in one of the sessions, I was just asking background information for the families, and no one knew what their child's GMFCS level was. And so that was really, we took a step back and went, wow, they really don't know that much about their child's diagnosis and what that could mean as well. And finally, so we are working towards building a starting point is an information booklet. And so you'll see this again pop up throughout the intermission slides, and it will come probably up in the chat box now, that you can actually access this little online survey again and share your thoughts on what might be interesting or helpful for a little information book. Finally, I just want to note also that our capture work wasn't just about our research projects. A lot has been done along the way to provide support and clinical education as well. We've trained over 100 clinicians across New Zealand in the HINE assessment. We've also helped to set up some GMs training and a network to help bring our GM trained assessors together. And we've been working to support new resources, implementing new strategies for change and building new partnerships, which a lot you'll hear about today as well. So there's a lot of really fantastic work across the region. So we're really excited to share some of our insights today, and that brings the background information to a close, but we are now going to bring in Sue to answer any questions that you may have for us. So if you haven't already typed them into the question and answer box, come on up and type your questions and we can answer them for you.